Yeah, brother. Let me do like this. Some gas. I can take this opportunity to wish you Merry Christmas. We have got 35 people here, and people are still trickling very, very, very slowly. This is the webinar. This webinar, I made this webinar in May this year, but many people could not join for various reasons. And I received many requests to say that, can you repeat that webinar because it's very important. But I made some changes in this. I included genital relaxation and a little bit of female genital cosmetic surgery in it, just to make it a difference. I couldn't just give it as it is, because pelvic organ prolapse and genital relaxation are one of the important occurrence in the human body, in the female body, as it grows. As you grow, especially after menopause, you'll experience this. Some people before menopause experience it. Many people, they asked me to repeat this because this is a topic that usually many people don't know what to do. So I decided to close this year with this webinar, genital relaxation and pelvic organ prolapse, because they go in hand in etiology, the clinical significance and social and physical effect on a woman's life. My name is Dr. D.T. Mahapa. I'm a urogynaecologist here in Polokwane. The topic for today is pelvic organ prolapse. Pelvic organ prolapse, as we see it, I want to go and see the, okay, I'll see that when we finish. Pelvic organ prolapse is a common condition for women who have delivered vaginally. Any woman who has delivered vaginally is called a paras woman. It is often associated with other conditions in a woman like urinary incontinence. The urogenital diaphragm is that part where the genital organs lie. I'll show you the urogenital diagram as we go. As you grow, it becomes lax, it ages, and lead to what you call vaginal laxity. This may lead to many problems in a woman, including unsatisfactory sexual intercourse and intimacy, that affecting also the psychology. And this being a very sensitive topic for couples to engage in due to various reasons. Some of them is cultural, some is religious, and some is just due to lack of proper terminology or vocabulary to address it. Because in some languages, mostly African languages, if you have to address it, you might sound like you are vulgar or you are insensitive. More especially in this era where they talk about gender-based violence. If a male partner can tell a female partner that, my dear, I think down there things are not as they used to be, it must sound like psychological abuse is gender-based violence, but actually it is not. This is one of the commonest causes, even before menopause, that causes vaginal garrulity, that queefing flatus coming out of the vagina because of genital relaxation. And Often, if there's a tear and a gaping, it's often lead to repeated vaginal infection because of the proximity of the anus to the vagina. But all these problems, women experience them, and they keep it to themselves. They keep them secret. If they keep them secret, nobody will know that they have it except the partner, who might not even address it properly. Most especially in our situation, we tend to keep quiet when we've got these problems down there. So today, we're going to talk about it, and I would like anybody to ask questions about it, to be fair and frank with one another on this topic. Let's define it. What is genital relaxation? Sometimes people call it vaginal relaxation. It's loss of vaginal integrity, which results from loss of the tone or the strength of muscles that surround the vagina and the ligaments. They become loose and they don't support the vagina very well. This is essentially a weakening process because of the collagen loss and age, sometimes due to trauma, and dilate the vagina, and that it loses its integrity and it distorts its ankle and its axis. So that affecting the optimum function of the organ. Looking at the pelvic floor here, this is what we call urogenital hiatus. It's surrounded by these muscles that are called levator ani. This muscles is called puborectalis. The baby is going to come out through the genital hiatus during childbirth, because one of the things that causes genital relaxation besides aging is childbirth. If there's dilatation and tore and distortment of this area, the urogenital hiatus become enlarged, and the organs start to protrude here, forming what you call pelvic organ prolapse. To get a good clue about it, you should look at the bony pelvis. Your waist is waist of a woman is made of a bone, which is called pelvic girdle, which is formed of 3 bones, the sacrum and the 2 pelvic bones. All these muscles are attached on these bones like a bowel, and they fill up the bottom of the bone. These are the puborectalis muscles that I've shown you later. The urethra comes out in front. In the middle is the vagina. At the bottom is the rectum. It's important to visualize this anatomy, in order to understand later what's going to come. If we go to the bottom side of the same, we find it like this. The urethra in front, the vagina, and the rectum coming. And these are the muscles that are found there. And this muscle, anatomically, we divide them into 2 portions, 2 triangles. The anterior triangle, which is called urogenital triangle, because it contains the urinary and the genital system. And the posterior triangle is called the anal triangle. This is when we saw pelvic floor relaxation, we mean distortion of these 2 triangles. The division in the triangle is just for descriptive purposes. What causes this? What's the pathophysiology? The pelvic organs are mainly supported by the levator ani muscles. Levator ani muscles are those muscles that I've shown you here that fill up the pelvis. They support the pelvic muscles. And there's a connective tissue network connecting these organs and muscles together, and together with the bone by means of fascia and ligaments. The genital prolapse happens when this supporting structure is weak, either through direct muscle trauma like during childbirth, neuropathic injury with nerve injuries, disruption or stretching. And this stretching is called pelvic floor relaxation. If a person has got those stretched muscles, we say his pelvic floor is relaxed. And the commonest culprit of pelvic floor relaxation is vaginal delivery. And the main causes. There might be other causes like trauma, menopause, but the main cause, vaginal cause, is vaginal delivery. It's the commonest culprit in formation of pelvic organ prolapse and vaginal laxity. This happens usually in animals that stand upright, like human beings. Animals that walk on 4 legs, They don't have gravity pulling the organs downwards, so they really have pelvic organ prolapse. We are the people that will have pelvic organ prolapse. And to understand this pathophysiology, some knowledge of anatomy is important. That's why I start with anatomy. The pelvic floor muscles, the function is to support the organs, the uterus, the vagina, the urethra, and the rectum. And it assists in continence, urinary continence and fecal continence. The ability for you not to soil yourself with feces all the time is because of the integrity of these muscles. The fact that your urine is not leaking all the time is because these muscles are intact. And it also aids in sexual performance. And it also stabilizes the joint as you walk. And they also help as a lymphatic pump to pump the lymph from the lower limb upwards into the pelvis. It's got many functions. And we divide these pelvic floor muscles into 3 layers. The superficial layer, which is called perineal layer, which is innervated. The nerves that supply it is called the pudendal nerve. The pudendal nerve is the nerve that's called sexual nerve. And this superficial layer are the muscles that are called bulbospongiosis. The bulbospongiosis is muscle that is called vaginal sphincter. Is that erotic muscles that surround the vagina that during arousal disengaged with blood and become thick. And there's also superficial transverse perineal muscles, which stabilize the perineum. I'll show you the perineum later. And the external anal sphincter, with the muscles that keeps the anus closed so that feces mustn't come out as they wish. That's a superficial layer of muscles. The middle layer of muscle is deep urogenital diaphragm layer, which is also innervated by the same nerve, the pudendal nerve. And it only consists of only 2 muscles, compressor urethric. Compressor urethric is one small muscle that it compresses the urethra and closes the urethra so that urine mustn't come out. It must come out when you want it to come out. And deep transverse perineal muscle, which is deeper than superficial transverse perineal muscle, and stabilizes the perineum and help in the continence. Then we got upper deeper layers called the pelvic diaphragm, which I'm going to show again, which is innervated by sacral nerves from sacral root number 3 to sacral root number 5. These are the muscles that are called levator ani muscles. They consist of pubococcygeus muscle. The pubococcygeus muscles have got 2 components. Pubovaginalis, which arise from the pubis and turn around the vagina, and puborectalis, which arise also from the pubic bone and turn around the rectum. And at the lateral, you've got ileococcygeus. And the tail muscle, which is atrophied in human being, is called a coccygeus muscle or ischiococcygis. These muscles, you can appreciate them in this fashion. The green one is the one that I told you, that bulbospongiosis, the vaginal sphincter. Superficial transverse perineal muscles and deep perineal muscles, they stabilize the perineum. The perineum is the area between the anus and the anus. And then you've got levator ani coming like this, puborectalis and pubovaginalis. Then you've got coccygeus muscles, which is a tail muscles like this. These are the muscles that form the pelvic floor. DeLancey is the one people who have revolutionized the pelvic floor anatomy and understanding. He divided into 3 levels. The support of the genital organs are divided to 3 levels. There's level 1, which is supported by the cardinal ligaments and uterosacral ligament. There is a complex that provides apical attachment of the uterus to vaginal vault and bone and keeps the vagina, the cervix where it is and the uterus where it is. If there's disruption of this level 1, cardinal and uterosacral ligament, uterine prolapse will occur. And when the uterine prolapse occurs is when the cardinal and uterosacral ligament complex break or is attenuated or is overstretched, like in childbirth. Then we've got level 2, which is the white line, acrostentinous fascia pelvis, which is not a very strong, but it stabilizes the middle part of the vagina. The level 3 is the lower part, which is the urogenital diaphragm and the perineal body, which support the lower part of the vagina. We have seen this perineal body earlier on. And He divides it into this way. The level 1 support the pelvis. The level 2 supports the mid-vagina. The level 3, this is the perineal body. It supports the perineal body. This is more or less to understand it. What is the etiology of pelvic organ prolapse and genital relaxation? Chronic cough. If you keep on coughing, you increase intra-abdominal pressure. It will give rise to genital relaxation and pelvic organ prolapse. Some people are born with congenital defective genital support, like connective tissue disease, but the biggest culprit, as I've said, is childbirth. But you can't stop childbirth because you don't want to have genital prolapse. If you have it, it's treatable. During pregnancy, there's softening of ligaments and muscles to allow for the coming of the baby. And after pregnancy, they don't return to normal where they were before. So that's why we have that. And people who do manual work, more especially with these days with women equals to men, the manual work increased intra-abdominal pressure and put pressure on the pelvic floor. Epidemiology. We don't know. The incidence of this condition is difficult to determine because of geographic area. You wouldn't know how many people have got genital relaxation in the far rural area where health facilities are not accessible. More especially in South Africa, there's no data collection which you can say the prevalence is so much. It varies widely across studies depending on where the study was done. Most studies are done in the first world country because there they keep the data. But it can affect every woman of all ages. Although it's more common in older women after menopause, it doesn't mean it can affect people before menopause. It can. It is said that in the literature, half of women who have given birth vaginally have got some form of defect in the pelvic floor. They either have a mild degree of genital relaxation or mild degree of pelvic organ prolapse. And only 10% to 20% will seek care. I take it further and say not only 10% or 20%, 5% in the African population, they'll take care, they'll come for consultation because I see them very late when the condition is very, very advanced. In the United Kingdom, around 48,000 women, they remove their uterus each year because of pelvic organ prolapse and genital relaxation. So prolapse is the commonest reason for removal of the uterus in the women over age of 50 in the white population. This is a South African study done by Hilton Hayes. Hilton Hayes was the gynecologist. He was once the head of gynecology in Pretoria University. He did a study and found that half of the women in the white population would remove the uterus because of pelvic organ prolapse. And I did a study as a prerequisite for my Master of Public Health on hysterectomy and found that 93% of abdominal hysterectomy in Black population, I was studying Black population, is due to fibroids. While in whites, 50% of them do hysterectomy because of pelvic organ prolapse. While majority of Black people, when they remove the uterus, is because of fibroids. And of those, if you divide this abdominal hysterectomy, if you look for go to vaginal hysterectomy, 32% of vaginal hysterectomies in my study were due to pelvic organ prolapse. So we do find pelvic organ prolapse in the Black population. If you look at the graph here, the vaginal hysterectomy is the brown red. The blue one is abdominal hysterectomy. If we look at the vaginal hysterectomy, this 32% of them at the highest is due to genital prolapse, which are the pelvic organ prolapse, while majority, 93% of abdominal hysterectomy were due to fibroid uterus. Fibroids are more common in Blacks. I must emphasize that nobody is spared from having genital prolapse. It doesn't matter how you look like outside. The pelvic floor can give in. It doesn't matter whether you are exercising heavy, whether you are obese. There's the tendency that obese people are the ones that will have it. No, it's not true. Everybody can have it. It's just more common in obese people because they've got more increased intra-abdominal pressure. But everybody can have it. What are the risk factors for genital prolapse? The risk factor for genital prolapse, we can divide them into predisposing factor and inciting factors and promoting factors and decompensating factors. Predisposing factors for genital prolapse are genetic. If you are genetically have a weak connective tissue, you are going to have pelvic organ prolapse. And of course, male will have less genital prolapse than female because of anatomical configuration of the male and female genitals. Inciting factor, which is incited, is pregnancy and childbirth. It followed by injury, trauma. Now, with the advent of and the high degree of removal of the uterus, hysterectomy is one of the causes if it's not done properly. And with nerve injuries and nerve diseases, neuropathies, and muscle diseases, they can also weaken the muscles and predispose to pelvic organ prolapse. Promoting factors are those promoted obesity. I've said that it can happen in anybody, but obesity, because it increases intra-abdominal pressure, it will predispose to genital prolapse. People who cough a lot because of pulmonary disease, when you cough, you increase intra-abdominal pressure. When you're constipated, chronic constipation, when you go to the toilet, you push so hard that you're increasing intra-abdominal pressure, and that causing a strain and stretch on those pelvic floor muscles. Some recreational activities, depending on how you are, whether you are lifting things or you're squatting, or the type of gym that you do, heavy lifting, the type of dancing that you do, can cause damage to the pelvic floor. Of course, decompensating factor is unavoidable. It's age. As you age, your muscles will atrophy. And menopause, you cannot dodge menopause. One day you reach menopause, there will be hormone deficiency and atrophy of the muscles. You know, a pelvic floor, if you look at it previously, it looks like it's like a hammock. If you sit on a hammock like this, you can stretch it and stretch it. Later, it will go down. If you compare this hammock with this bowel, if you put something in this bowel, it may go down like a hammock, like that hammock, somebody sitting on the hammock. And if the weight on the hammock is too much, it will stretch downwards. The same will happen to the contents of the pelvic floor. The pelvic floor hammock, all organs that are inside the pelvic floor, they exert pressure and weight on the pelvic floor. And there's this progressive sagging and lengthening of the pelvis ligament and the muscles that causing the pelvic floor relaxation. You know, I always tell people that a human tissue is like a rubber of poor quality. If you take a rubber of poor quality of about 10 centimeters and you stretch it to 20 centimeters, when you leave it, it doesn't recoil back to 10 centimeters. It will be about 12, 13, 14. That's how a human tissue behaves like. So if it's overstretched, it doesn't recoil back to its normal position. So I want to just imagine if the pelvic organs are sitting on the pelvis and due to recreation or other thing of birth, everything is on the pelvic floor. Say that trampoline is a pelvic floor. Later, the trampoline will sag and be down because on the pelvic floor, many things happen. Recreational activity, urination, coughing, defecation, childbirth happens on the platform of the pelvic floor. But the pelvic floor, as it's like a rubber of poor quality, it will sag down. Another analogy that I usually give to students, pelvic floor is like a basket. If you fill up contents in a basket, depends how much you fill up, you might injure the bottom of the basket. The bottom of the basket might just torn and they fall. This basket is like this bowel, which is a pelvic floor. It's filled up with organs. Depending on how many organs, how sick they are, it sags the muscles. It sags the pelvic floor. So this bowel, which is sitting on the pelvic floor, which is muscles attached to pelvic bone, and the contents are the uterus, the intestine, the bladder, the urine, all the contents. And depending on what the contents will do, it might form a bulge. And that's what we call pelvic floor relaxation, which will predispose to pelvic organ prolapse. The contents in here, if they are just normal contents, the danger will not be that much. The commonest cause is if they are heavy. You've got heavy fibroids in there, you've got a heavy uterus there, adenomyosis, cysts. Some pelvic walls, they're carrying fibroids as heavy as 13.2 kilograms, like you see this uterus, which was 13.2 uterus, which was taken out of this woman, would injure the pelvic floor too much. But not every woman will have that. But this majority of women will have. Pregnancy. A 3.2 kilogram baby there for 9 months, exerting pressure on the pelvic floor is likely to cause sagging of the pelvic floor and cause pelvic floor relaxation. That predisposing to pelvic organ prolapse. The area of damage that happen is first start at the bony pelvis, the pelvic that I've shown on the bony pelvis. The cardinal uterine ligament, the one that I said is DeLancey level 1. Pelvic diaphragm, the levator and the muscles that you have seen in the bowel, and the urogenital diagram, which consisted of the superficial perineal muscles and the external anal sphincter that we see, which coalesce at the perineal body. The perineal body also all the muscles that meet there can be torn. Even the vaginal wall sometimes can be torn. So this is the perineal body. If it damages at the center, everything got loose. If the center cannot hold, everything got loose. These are the ligaments that attaches. The transverse cervical ligament is what we call the sustentaculum of Bonis. Ligaments of it's got many names. It's called transverse cervical ligament, it's called cardinal ligament, it's called sustentaculum of Bonis. It's the same ligament that attaches the cervix to lateral pelvic wall. And we have got pubocervical ligament from the pubis to the cervix. And then you're going to have uterosacral ligament, which attach from the sacrum to the uterus. These are ligaments that keep the cervix at its own position. In the sagittal section, you can see uterosacral ligament, pubocervical ligament attaching there. If there's any tore or undue strain on this ligament, they will stretch or be torn. All these organs that it support will fall down, that causing pelvic organ prolapse after genital relaxation. Recreational activities. I always warn women that you must be careful what you're doing. These organs, if the organs have got fibroids inside here, this is a normal uterus, this uterus with fibroids. Fibroids are heavy. Or if you've got a cyst inside here, the cyst can be, if they are big, the exact weight, they are heavy. It must be if their cysts are mobile, are not attached to the wall. And some women tend to think it's common, it's nice. Let's imagine this. Just imagine what's happening if she has got fibroids there and she's postmenopause and she dances like that. That's a recreational activity. As time goes on, she will present with all these twists causes strain and stretching on the ligaments that support the genital. Just imagine what's happening to the pelvic ligament with that dance. What are the symptoms? The symptoms of pelvic organ are non-specific. They differ from any department. By symptomatology, you cannot tell what it is until when you examine. They are non-specific. But one of them is pelvic pressure. The woman will tell you, I feel pressure down there. I feel there's a vaginal bulge there. When I put a finger, I feel something. I feel something when I insert the finger in the vagina. I feel like something is falling. I feel like I'm sitting on the ball. And it usually, because as it stretches, it pushes the uterosacral ligament and pull it. There's this chronic low back ache, which in the morning is not there. As the time goes on, in the afternoon, it becomes worse. And also, most women complain of the vaginal flatus, which is vaginal wind, garrulity of the vagina, during sex or during sex, which is called queefing. I'll show you queefing later. The conditions that from pelvic organ prolapse are what in the layman they call dropped vagina. The woman will say, my vagina is dropping. And sometimes you might just come off the companion of repeated vaginal infection. This is because of the proximity of the anus to the gaping vagina, deficient perineum, or vaginal laxity. This vaginal sphincter, the bulbous spongiosum, doesn't close so tightly. So the sweat from the anus with its contents, which is dead, goes easily into the vagina. Some women will come complaining of urinary incontinence, overt urinary incontinence, or urinary retention, mostly urinary incontinence, and repeated vaginal infection. Very rarely, but often, they present with fecal problem, defecation problem. The feces just comes out on their own. They might have fecal incontinence, or they'll have fecal trapping. Fecal trapping, I mean, she goes to the toilet to go and pass feces. And when she finishes, she still feels that there's something inside there. This is because if he has got a rectocele, when the feces come through the rectum here, supposed to come out through the anus, some of the feces, they trap here and they don't come out. When she finishes and wipes herself, she can still feel the sensation that the rectum is full. More often, she might have to take a finger and push this rectum backwards and push this feces so that they must come out to evacuate it. This is a picture of genital prolapse where you have increase in the genital hiatus and all organs will protrude here. What's protruding here is the bladder, is a cystocele. And the perineum, usually the perineum and the genital hiatus are the same length. The perineum becomes shorter. This means there's a deficient perineal muscles. As you can see in this one, because of a tear from old deliveries, the perineum is small, but the genital hiatus becomes big. And it can even go to an extent where if you've got with home deliveries, which are not cared for in rural area, the tear can extend up to the rectum. And that way the woman cannot control her feces because the anal sphincters are destroyed. The feces keep on just coming out of there. And this is very embarrassing and this is very disturbing. And as I say, majority of people, they keep it quiet to themselves. Why these things are treatable, and after treatment, you can still regain yourself. This is the same woman that has been treated. She's like any other woman. I say this because many women, when they come to me, they don't tell symptoms straight. Very few tell straight. They just say something coming out there. What is something that's coming out there? We don't know. But I have to dig this information. And some women, they'll really confess and say something. Always when I walk, when I dance, when I have sex, I stand up, there's some flatus coming out of my vagina. And this is not flatus. It's what you call queefing.
Did your vagina just fart? This is known as queefing, the involuntary passage of air from the vagina. It happens because during certain activities such as running, yoga or sex, air can enter the vagina. Since the vagina is a collapsed muscular tube, the collapsed walls can trap the air inside, which is then released when you change posture or when something is introduced into the vagina. The air vibrates the vaginal tissues on the way out, causing the noise that you hear, which sounds like a fart.
This is most women present with that. And I think we must teach this.
Have you
very
ever
common.
struggled with queefing or farting out of your vagina? It could be very embarrassing. Lots of clients that practice yoga very often tell me that it happens when they're coming out of an inversion or when they're coming out of a position with their legs on the walls. Nobody wants that to happen. It can be annoying and embarrassing. Why does it happen though? So very often it can happen for three common reasons. The first one is pelvic floor weakness. So of course I recommend that you go to a pelvic floor therapist. If you have pelvic floor weakness, it can cause laxity around the tissues that open and close the vagina and allow air to get in. And then when you come out of an inversion or a position or out of down dog, air can escape and cause that embarrassing farting noise. The other reason why it may happen is if you've had a scar or you've had childbirth and have had a tear or an episiotomy, and that scar tissue decreases the contractibility of that tissue, which also prevents you from closing optimally, which can allow air to get in and then embarrassingly escape when you come out of an inversion or down dog or legs up on a wall position. And the third common reason is poor pressure management. So if you're holding your breath or bearing down, that could be another reason why you're queefing. So what do we do about it? There are a few easy things that we can do to.
The treatment of queefing is usually done by the physiotherapist, but pelvic organ prolapse and pelvic floor relaxation, how do we approach it and treat it? We treat it in this way. Rebecca Shika, please wait, don't draw here. Rebecca? Sometimes, if it's mild, we just observation. And with physiotherapy, they do what you call pelvic floor rehabilitation. More especially those people who cannot undergo surgery, very old people, frail people. We even use pessary as a measure because they cannot stand surgery. But if a woman is fit for surgery, we can operate and restore the normal anatomy. If it's minimal in a woman who's sexually active, the radiofrequency equipments are there in the market that strengthen the pelvic floor muscles and vaginal muscles. These are usually used in a procedure called vaginal tightening. Depending on the symptom severity of prolapse and the general health and activity of the patient, you choose the type of treatment. There is no correlation between the pelvic symptoms and the extent of prolapse. Some people with very grade 4 prolapse have got few symptoms. Some people with grade 1 prolapse have got severe symptoms. There's no correlation. As the first treatment in any way is non-surgical amendment. Don't do surgery. Do adjunct therapy, non-surgical amendment, to decrease the frequency of the symptoms and delay surgery and prevent worsening of the treatment. This is observatory management, like pelvic floor exercises, Kegel exercises, which improve the symptoms of mild prolapse by strengthening the levator ani muscles, and it only concentrate on the pelvic Kegel exercise, which are done mostly by the physiotherapist. The
pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front to the tailbone at the back, and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control and sexual function. If your pelvic floor muscles don't work well, you may leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscles. To switch on the pelvic floor muscles, you need to squeeze and draw in the muscles around your vagina, as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks. Then let go and relax the pelvic floor muscles completely.
These are the animation of what physiotherapists will teach you. But in majority of women, because they come late, we do a palliative, not curative, just so that they can live a normal life. Because they come with pain. And there are two types of backaches that they come with. Backache can be, there's a gynecological backache and orthopedic backache. Gynecological backache is a lower down backache from the L5 downwards. And from L4 upwards, if its backache is high, is orthopedics. Because if it's L5 downwards, it's from the pelvis, it's gynecological. The pessary improves the circulation and it treats the gynecological pelvic pain. And it keeps the patient in optimal condition before surgery with good blood flow there before surgery. As this is the pessary sitting in the vagina, pushing the vagina upwards, pushing the urethra backwards, that's helping in treating urinary incontinence. After insertion of the pessary, if the pessary stay for such a long time, it can cause erosion and should be removed and washed and estrogen cream be applied so that it mustn't cause erosion. That's why one cannot be on a pessary for the rest of his life. Let's describe the type of prolapse. Any condition in medicine, for you to describe it properly, you must subdivide. We subdivided the pelvis into 3 compartments: the anterior compartments, the middle compartment, and the posterior compartment. The anterior compartment contains the urethra. And if there's prolapse of the urethra, we call it urethral. And the anterior compartment also contains urinary bladder. If the urinary bladder prolapse, we call it a cystocele. If both urinary bladder and the urethra are prolapsing, it's called a cystourethral. In the middle, we have got organs in the middle. Is the uterus and the vagina. If the uterus prolapses, we call it uterine prolapse. If the vagina prolapses, we call it vaginal prolapses. If the woman has removed the uterus and the vagina can also prolapse after the removal of the uterus, we call it vaginal valve prolapse. If that valve prolapse has got intestines as its contents, we call it enterocele. That's why management of valve prolapse at surgery, you must be sure that there are no intestine there because you might cut the intestine. The posterior compartment contains only one thing, the rectum. And if the rectum prolapses, we call it a rectocele. Of this, the commonest that happen in female is cystourethral. It's the type of prolapse that happens and followed by the uterine prolapse. The anterior compartment, the prolapse is caused by what we call urethral hypermobility, which is the cause of urethral, which the urethra of a female is very short. It's about 4 centimeters in diameter. Being 4 centimeters in diameter, unlike a man's urethra is about 12 centimeters in diameter. And a man has got additional protection from the prostate that makes it not to fall. And if there's urethral hypermobility, we test it by what we call cotton wool swab test. We put a cotton wool swab there and let the woman strain and see if the arc that's formed by that is more than 30 degrees, then we know that this is urethral hypermobility. And if left untreated, later it will be accompanied by stress urinary incontinence. And if the bladder prolapses, of course, we call it a cystocele. There's another condition that is part of prolapse, and many people are diagnosed as prolapse. In doctors, if they don't examine very well, they diagnose it as prolapse, but it's not a prolapse. It's called elongation of the cervix. With chronic inflammation, vaginal infection, edema, the cervix might just elongate on itself with all the uterus and other organs in their normal position, and it protrudes through the vaginal os. Another thing that can cause elongation of the cervix is trauma of the cervix during difficult labor. And in that way, there's no prolapse on any pelvic organ. Only the cervix has come down, and what's prolapsing is only cervix. It becomes so long that it protrudes through the hymenal ring and visible through the pelvis. Treatment of cervical, of cervix that has elongated and prolapsed through the vaginal os is not like treatment of pelvic organ prolapse. It's the type of treatment which you call cervical amputation and Manchester fixation of the cervix. This is the type of prolapse that you see, only the cervix coming here, and one can think, is this a uterine prolapse? The uterus is at its normal position. Is that the cervix is so long that if you do hysterectomy, you will realize that the cervical length is more or less the length of the uterus. That's cervical elongation. And many people refer patients to me and say, she's got uterine prolapse. And I only find that it's elongation of the cervix. Let's go back to urethral hypermobility. Damage to the ligament that attaches the pubis to the urethra, which is called pubourethral ligament, and damage to sphincter urethrae and the laxity of the urethra will lead to urethral hypermobility. And if it protrudes, it will call urethrosul, and it can even be seen through the introitus. I've said that with that pin, if we put an object, light object, a cotton wool swab stick inside the urethra, and ask the patient to strain Valsalva maneuver to increase, to push. If this thing goes up more than 30 degrees, there's urethral hypermobility, which is demonstrable very clearly here. This is the urethra that's facing you. If you ask this woman to strain the urethra, it turns and faces backwards, downwards towards the clitoris. That is hypermobile urethra, and the urethrostool is visible here. This, a woman can witness it when she's in the toilet. If she starts to urinate and the urine goes forward, like she's a man, she's not urinating downwards, she's urinating forward. There's urethral hypermobility. If you're sitting on the toilet seat, urethra should point downwards and urine should go downwards. If urine goes too much forward, there's urethral hypermobility. And if not treated early, chances are that in later it's going to injure the uretrovesical sphincter and cause urethral stress urinary incontinence, because the main support of the urethra and the bladder, which is pubocervical fascia, will have been damaged or torn. And this midnight weakness will form urethrocoele or cystocele. And we can divide the cystocele into grade it, depends on severity. The first degree of cystocele is the anterior wall of the cystocele of the vagina is visible from the urethra to the posterior fornix. The second degree, the inferior wall of the vagina wall extends outside the introitus, it comes outside. The third degree is outside, and there's also bladder coming out with it. The fourth degree, the full length of the urethra and the bladder are outside. Majority of women come to consult in the third and fourth degree because they think first and second degree are not. But while if you treat first and second degree, you will avoid third and fourth degree. Let's just animate the bladder prolapse here. The bladder is sitting here. Let's go back again. We'll go back to it again. The bladder is sitting here. Until above this is the uterus, and there's the rectum. This is a normal position. With descent of the bladder, if the bladder descends backward, downwards, like it does in this case, it pulls with it the uterus and protrudes through the cervix, through the vaginal entrance there. This is how a second degree urethrocoele, cystocele is like. This is the bladder wall. Because of the torn muscles here, if you push, the bladder comes. You can see the urethra is facing upwards. This is a urethral seal, and a person can put a finger here and say, I'm feeling something there. Let's go to the middle compartment where there's a uterus and the vagina. The level 1 damage, uterosacral ligaments, are the cause of the middle compartment damage. And the commonest cause is labor, most people precipitous labor. The labor that say, push, 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 and you push a 4.5 kilogram baby. They tear the ligaments and cause middle compartment. And chronic cough, of course, heavy manual. Hysterectomy, if well done and the ligaments well torn, very rarely will give you valve prolapse. But we still find a lot of valve prolapse because of hysterectomy, which was not done in a way that it should be done, where the uterus prolapses outside and it keeps on being outside. Let's animate the uterine prolapse and see. Here's the uterus. It's sitting up there, above the bladder. There's the cervix. There's the vaginal canal. If the level 1 ligaments, which is cardinal uterosacral ligaments, are torn, the uterus prolapses. And if it prolapses up to the level of the introitus, it's called grade 2 prolapse. And if it left, it will go further and prolapse. Part of the half of the uterus will be outside, half will be inside. That's grade 3. Grade 4 prolapse is what you call prosidentia. The entire uterus will be outside. The woman will come with the entire uterus. I see women coming mostly with grade 4. You wonder why didn't they come when it was still milder? Because it's easier to treat when it's milder. It's easier to treat rather than to treat a grade 4 like this one where the uterus is all outside. If it's still milder, it's easier to treat and the morbidity is not that much. You can even restore sexual function. But majority of the women that I see, you say push, you find that she says something is coming out there. If the entire uterus will be pushed outside and has been there for a long time, the partner knows he's there. Maybe the partner will run away, or the partner doesn't have it, or they just don't know what to do with this. They call it a witchcraft or something. We don't know. That's why I put this webinar as a awakening webinar so that people can know these things are there and they can be treated. And we look at as I told you, when the uterus was descending down, that we classify it depending. There are many ways of classifying it. The Baden-Walker system is the one that when descent is halfway through the hymen is grade 1. Grade 2 is what I've shown you there when I stopped the uterus. It descends up to the hymen. When half of the up is upwards, half is outside, it's grade 3, and maximum descent is prosidentia, which I've shown there. And vault prolapse, there's this tendency that after hysterectomy, then you are treated out of it, depending on your tissues and type of hysterectomy that is done. After hysterectomy, increasing abdominal pressure can lead to prolapse of the vault of the vagina, which is the vagina come outside, inside out, like a pocket inside out. And this is usually related to the quality of hysterectomy, where a woman has done a uterus, but now she presents with a vaginal vault. Vagina comes inside out, and it stays there forever. And it disturbs it. As it comes out, it distorts the uretrovesical angle. And this woman usually presents also with urinary incontinence and with vault prolapse. With the operation, it's more technical. I do about 1 in every 2 months of vault prolapses operation, where a woman will come with the uterus having stayed for a long time, and it's even dry. It's got scaly there, and sometimes eroded with bleeding. You ask her to push, the entire vagina just come inside out. You can see this has got scaly here, which means it has been here for a long time. It's always outside, it's even dry. And we do an operation called sacrocolpopexy on her. The posterior compartment, of course, contains only the rectum. Descent of the anterior rectal wall into the vagina is called a rectocele, which is also common in women who have delivered vaginally, most especially if they have sustained a tear of the vagina during delivery, or episiotomy was not stitched very well, and the perineum is deficient. or they've got chronic constipation and they do heavy manual work, the rectum will just prolapse and the feces will bypass the anus and be trapped in the rectum. And that way the woman will feel, after she went to the toilet, she will just feel, I haven't evacuated enough, which is called tenesmus, a feeling of incomplete evacuation. Rectocele is chiefly a herniation of the posterior vaginal wall to a weakness of defect in the rectovaginal septum. The rectovaginal septum is made strong by the special type of fascia, which is called fascia of Denon-Vallée. And the symptoms will include difficulty in passing stool, or a feeling of vaginal mass, or feeling of sensation of fullness there. And by examination with the rectum and the rectal examination and vaginal examination, we can confirm it. So the rectocele, the perineum, the muscles that causes which I said are vaginal sphincters, if they are intact, you won't have that. And sagging and funneling of the levator ani can cause predominantly pelvic floor relaxation, and also can cause you difficult urination. Let's show you this is the rectum, ne? Look at the rectum is protruding down. It's passing the anus, it's into there. If the feces comes, they'll lodge there and the patient will have tenesmus. The rectocele can be seen with a rectum. This is second-degree rectocele. It can be ovate and see it as it is like this, which can also trap feces, or it can be covert. Usually, the treatment of a rectocele is called posterior colporraphy. Use of laxatives and stool softeners doesn't help. It's just a temporary relief. Even partially doesn't help. You have to do posterior colporraphy, thorough one. If it's not overt, you don't see it, and the patient presents with symptoms like tenesmus, you must know that that patient doesn't have an overt rectocele. She has got a covert rectocele. Inside deep there, if we do a speculum, you'll find that there's a rectocele which is not protruding outside, but inside the vagina, and the feces are trapped there. That's why she's complaining of tenesmus. What are the indications for repair? You repair only when it protrudes through staining or is progressive, or is symptomatic and lead to abnormal vaginal access. Always when you do hysterectomy for another condition, you find a rectocele or a cystocele, it's best practice to repair it at that moment, to take that opportunity, because in the treatment of prolapses, the first treatment must be the best one. If the first treatment fails, the second treatment doesn't do very well. So the choice of a treatment at the first time must be the best one, because the first surgery is the best surgery for cure. What kind of surgery do you do? The aim of the surgery is to relieve symptoms and the quality of life. The symptom associated with lower genital tract and urinary tract. In some women, this means an attempt to restore normal vaginal anatomy and Anterior improve sexual function. Because if a woman is still sexually active, you must restore the sexual function. In others, an obliterative procedure is more appropriate. Obliterative procedure, I mean, you close the whole vagina with the procedure called colpocliasis. This has the result in the fact that it relieves symptoms, but the woman at that time, she mustn't be sexually active. That is usually done in very elderly women, not in some. But majority of women, we must try to improve the vaginal access and vaginal function, because majority of women who come with this for these conditions are sexually active. And then the principle of surgery is that repair the site where you think the injury is and rebuild the weakness. And the goal is a vagina of normal depth and the axis. The muscles must be reappropriated in such a way that the woman goes to near normal. Surgical procedure, a simple hysterectomy for prolapse usually is vaginal hysterectomy. Anterior repair or paravaginal repair can be done alone or together with hysterectomy, or posterior repair or repair of rectocele can be done. And I said, if there are intestines inside the rectocele or inside the enterocele repair must be done. If it's vault, you can't repair it vaginally. You have to do what we call vault suspension. If there's a relaxed vaginal outlet, of course, perineoplasty or vaginoplasty to repair the vaginal outlet will be done in the same place. I'm going to put on my Facebook 2 podcasts after this. You just visit that Facebook. My Facebook page is DT Mahapa. If you visit it, I'll show you I'll put 2 podcasts that explain very well relaxed vaginal access, and many women can learn from those podcasts. I'm going to put them about 10 minutes after the procedure. I'll put them on the website. It will teach you on perineography and relaxed vaginal outlet, which I could not cover here adequately. The Facebook page is DT Mahapa. This condition, which is part of pelvic organ prolapse, where you've got relaxed vaginal outlet, which if switched very well, this is before and after in the same woman, the woman's confidence can be restored. If there's a concomitant rectocele, like in this woman, it can be repaired, and perineoplasty or vaginal repair can be done, and afterwards the woman can be near normal. And I've said if there's a vault prolapse, we do a procedure called sacrocolpopexy. We put it inside, and with a mesh, which is a synthetic mesh, we put it on the apex of the vagina and attach it to the sacrum. That's an operation, which is an abdominal operation that must be done. Or some people, if it's frail, you can do what you call sacrospinous fixation, which should not be done if a woman is sexually active, because sacrospinous fixation, it distorts the axis of the vagina to the side of the sacrospinous ligament where you have attached the vault. This is done vaginally. The advantage is that it's a small surgery, and if a woman is not, it's an aesthetic risk, you can do it. You can even do it, they try to do it bilaterally, but I prefer to do it once because I do it on very elderly, 80s, 75, 80 years old. But a young person with vaginal laxity, which is just dilatation of vaginal opening, vaginal canal, will come with absence of vaginal ruga because of menopause and diminished friction and stimulation, will need a special treatment. Most people, if it's accompanied by queefing, we need special treatment because the decrease in genital pelvic sensation during sexual intercourse, it adversely or negatively impacts sexual life and the quality of life. And usually I found it that it's common. Previously, in our forefathers, we used to have polygamous marriages. And you would tell us what encourages polygamous marriages, because the first wife, it delivers and have vaginal laxity. And as he goes towards menopause, lose vaginal ruche, sexual friction diminishes, and she starts to have queefing, then marry another one. As time goes on, she goes through the same process, we marry the third one. Until the third wife in a polygamous marriage is more or less the age of the firstborn of the first wife. But these days, we cannot live with polygamy. Women used to be assets. Now, women are liabilities. The more you have women, the more you spend more money. And especially if the vagina lacks vagina, it comes with vaginal infection because of the proximity of the anus. And then it reduces the self-esteem of the woman. The confidence in and outside the bed of a woman is reduced. And in oldest days, we used to treat it by polygamy. Now you can't treat it by polygamy. Nowadays, what's the treatment? The treatment of all those is infidelity. They call them blessers. They just cheat because they don't know, people don't know that this can be treated. Then they cheat. The partners start to be in that infidelity. Although causes of infidelity are common, some partners are just silly by nature, but diminished sex, vaginal laxity is one of the commonest cause of infidelity. And women, because men, men, banale with Lailanyana, then when they are with their concubines, with their nyatis, they tell their nyatis how their wives are at home, that they've got queefing, vaginal laxity, diminished friction, anorgasmic, and all. They tell this nyatis here. They say, you are new nyati, you are better. My wife is like A, B, C, D. Then the next thing, Masadu tell like the nyati. So the best thing, women, if you want to keep your husband, if you realize any of these things, to stop this blessed situation, attend to it. Then I'm not guaranteed that it will stop infidelity. Some women are just dog by nature, so you can't stop them. Some men are just silly by nature. You can't stop them. But majority of men are chased at home by the wife's conditions, which they don't know that it can be treated. The commonest cause I've said is vaginal delivery. You see, cesarean section, it spares the vagina, it doesn't go through the vagina, so it remains intact. So the best way to deliver a woman, I would think, would have been cesarean section. I've got my own reason, because also I do more cesarean than vaginal. Because my reason is that previously they used to say cesarean section, you can only do 3 because complications become worse after the 3rd Caesar. But tell me, what is the average family size of a Black woman? The last study that was done by Professor de Villiers of Medusa, the Black woman, the average family size is 3 children, and majority have got 2. Nobody has got 4 or 5 children these days. So to spare this process, which the baby pushing down there and distorting the fascia and the ligaments and tearing the perineum, the perineal body, as the head comes and twists, episiotomy, which is not well healed, and it's got its own consequences, which later affect the quality of a woman. And majority of people, when they tear, if they're home delivery, the tear will go towards the anus. While actually, if it's a controlled tear, which is called episiotomy, they do what they call mediolateral episiotomy to spare it towards going towards the anal sphincter, so that even if there's a tear, it mustn't injure the anus. It is my principle that every woman who delivers vaginally should have an episiotomy. But episiotomy is cannot prevent genital prolapse, cannot prevent genital laxity, cannot prevent vaginal laxity, but it just diminishes the degree of that. But some women will praise themselves and say, I delivered without episiotomy. That means a danger. Whenever I find a woman, I delivered without episiotomy, I know danger is coming now. So there's a damage in the perineum. Normal vertex delivery without episiotomy is a danger in itself, because it just tears the entire perineum here. And if you don't see it, if you remove the skin here, you find that these transverse perineal muscles, they are torn inside here, you don't see them, and the perineal body is lax, and then to have relaxed vaginal sphincter, which is with a gaping introitus, repeated vaginal infection, queefing. If it's home deliveries, the tear, I said, it goes towards the anus, then it injures the anal sphincter. And you can even see this is the 3rd degree tear, which, because women deliver at home and they don't go to the hospital to be sutured. Every 3rd degree tear, the vaginal tears can be divided into 1st degree tear. Only the mucosa, vaginal mucosa, it can be stitched under local. 2nd degree tear, the muscles are involved. Once the muscles get involved, it must be stitched in theater under anesthesia with good relaxation, because these muscles, after they've torn, they recoil far. You must go and search them, and you can't search them when the patient is not under anesthesia. So is the 3rd degree. The muscles are torn, the perineal muscles are torn, and part of the anal sphincter is torn. The 4th degree is the worst one, where not only the anal sphincter muscle, even the anal mucosa is torn, which means the vagina and the anus is the same thing. From 2nd degree, 3rd degree, 4th degree, it must be repaired in theater. Whenever I see a woman said, I have the tear, where did they repair it? They say in the ward. I know that they missed these muscles, because you can't go and look for them when they're like rubber. They recoil and go and hide somewhere near the pelvic wall. If the patient is under anesthesia, you can take your time and go and search for them and bring them together and suture them layer by layer until you construct a good anal sphincter, a good bulbous spongiosis, a good perineal body. But you cannot, otherwise you're going to end up with a woman with a gaping introitus, because the vagina should be going up to here. Because this episiotomy was sutured in the wart, then the problem is vaginal laxity. Nowadays, we see even young women coming with procedures that are promoted by the lay magazines. They call it vaginal rejuvenation. They want to rejuvenate their vagina. Some people call it all name. They call it a designer vagina, vaginal tightening. It's got so many names for it. It's in fashion because of increase in, it increases satisfaction in sex. Because women have realized that without good satisfactory sex, there's no more life in the family. And another thing that makes women to do this is because this difficult topic that is difficult to discuss with the husband, they come looking for treatment without their husband knowing. Because at morning home, you can't discuss, very few couples discuss the quality of their sex for various reasons. And one of the reasons is lack of appropriate terminology and the indoctrination that we have been used that any genital organ, if you say it in vernacular, is vulgar, which is indoctrination that was brought to us by Christianity. But in their languages, you can talk it. That's why I can talk willy-nilly in their language here. But if I was to give this webinar in my mother tongue, people would say I'm being insensitive, which is what the Christianity has done us when they started indoctrinating us that our language is filthy. It is the duty of us as healthcare providers to alert you and advise you that these conditions can be treated. You shouldn't just lie down. And you know, with a man as it grows, living when he's young, for ejaculation to occur, you need tight vagina, you need good friction on the penis. And for a woman to get satisfactory sex, you need good friction at the G-spot to reach orgasm. And then, you know, in a man, the latency period between ejaculation increases with age. A young man can ejaculate now and start after 30 minutes another round of sex, but the old man cannot do that. And an old man need a tight vagina. That's why polygamy, they always marry a younger one. And women have realized that these women, they go for the younger ones because they look for tighter vagina. That's why they call them blessers. They don't go for the older ones because they need this satisfaction, which can be restored at home if there has been a tear. I've got this life cycle of a man. You see, a man at 13 and 31, the horse is jumping high. It's still jumping up to 41, up to 50, it can still jump. But from 50 onwards, it starts to be lazy. More especially if it's 50 to about towards 65. After 65, really, it does run, but it doesn't run very well. So this is the time when it needs good friction, and they go to small ones, they call them blessers. So to avoid that situation of blessers, correction of vaginal laxity, like this, and you end up being like this. Some people call it vaginization, or if you've got vaginal laxity with prolapse, like in this situation, you know that is a no-go area. A man will just ignore you. And at that age, you can't even divorce, you can't even discuss it. You know that your husband is going out. The only thing that he can bring home will be HIV and AIDS. So to avoid him going out and get HIV and AIDS, got a condition like this, treat it, and you'll end up being like this one. This is the same woman before and after. We had a vault prolapse, was repaired, and then later she became like this. And she regained her confidence. I've got another woman who told me that the vault prolapse, she has this vault prolapse because the husband has got a Nyazi. So the Nyazi is a witch, well, he bewitched her so that the husband must not come to her. It's not true. It's not true. These things can be treated. It's just that the information is not parted very easily. The common problem, which is embarrassing to women if they don't know what is queefing. I thought I should, although they talked about it, is the release of odorless air and embarrassing. Most people, if you are among people, you start to stand up, your vagina, you shift, you are standing with other people, and when you stand up, air has gone into the vagina, it changes. And during intimacy, they need treatment, which is called vaginal tightening and restoration of vaginal caliber, because it's like you know that your vagina is going to queef. It's like you can hold it, but you can't hold it, because when you move, you dance, you stand, you shake from any position, it can queef. If you've got a problem of queefing, there is treatment, non-surgical and surgical.
Farting from your vagina is not the same as farting from your anus. A fart is a cocktail of different gases released from the anus. These gases are produced inside the intestines by the action of bacteria breaking down the food that you've eaten. This then releases a smelly gas that we call a fart. Queefing is the involuntary release of trapped air from the vagina. Although the noise it makes sounds like a fart from the anus, queefing typically has no smell.
That's so. Lastly, towards the end, let's talk about vaginal, which I included it here deliberately as part of pelvic organ prolapse, because vaginal tightening and perineoplasty or vaginal rejuvenation, which is a condition that tightens the vaginal muscles and is part of the restoration of the perineum, and it reduces the amount of vaginal infection that you can have because of proximity of the anus to the vagina. It minimizes queefing. Of course, as an added benefit, enhances sexual function and boosts the orgasm. Although there's a procedure which is called short, which is an orgasm booster for those who are orgasmic, and a cosmetic look and elevation of the perineum. That way, it improves as sex by design. They call it improving sex by design and vaginization or designer vagina. Many women come requesting vaginal rejuvenation in that way, and it helps them. And I believe that it helps them. It looks cosmetic, but it's more. If the vagina is torn, that's a disease, because the morphology and the function of the vagina and the aesthetic look and the sexual function are compromised. So this surgery, which is called intimate surgery or vaginal rejuvenation or cosmetic vaginoplasty or aesthetic genital surgery, which are all its name, is one of the surgeries that modern women go through in order to maintain their self-esteem. Target organ for female genital cosmetic surgery, the target organs that we do are the mons pubis. Some people come from mons pubis design. Some people from labia minora design, which is called labia minoroplasty. Some people for clitoral hood design, which is called female circumcision. Some people come to reduce the vaginal orifice or vaginal canal, which is called vaginoplasty, which is the common that we found, either by fentonplasty. Fentonplasty is a procedure where you enlarge the vaginal orifice because it has been stenosed, mostly after menopause. Or perineoplasty. Perineoplasty is like posterior repair. If the vaginal orifice is too large, you reduce it and restore the perineal body, because the perineal body is the engine that keeps it. And that surgery is called female genital cosmetic surgery, which improves genital function and aesthetics, and it boosts your self-esteem. And the commonest culprit is childbirth. And vaginal rejuvenation, after it, you perform like a young girl, and they prevent partner infidelity. If you've got infidelity, if a woman comes for infidelity, I think one of the examinations might be sent to the gynecologist to examine whether she doesn't have anything that repels the husband at home. And because of some, in all, I thought this was very only, all Africans, they do what you call labial stretching. They stretch the labia of children when they are young. And when they are old, they go to the colleges, the ladies get embarrassed and they come and request labiaplasty, which is the reduction of the labia minora, which has been stretched and became large as a competition, encouraged by elders that you must stretch your labia so that you must get married, they must be big. But when they get old, they start to put on G-strings, and then with the G-strings that can't keep these labias, they come for the labial trimming, which is the operation that is done more common here, together with vaginal tightening, which is also one of the operations. The same patient before and after is like that one. The same patient before and after is like that one. It's a very satisfactory operation. Although the medical aids don't touch it, if it's the 4th degree tear with pieces coming out here, it will also be repaired. Also, the surgery is more intense, but if successful, before and after the same woman, find that it's a good, satisfactory operation. So this operation of vaginal tightening, the woman should know more about it and do it. The labia majora, many women, I can't see you people here. I'm going to look for a grid, but my grid is not visible here. Just mute yourself, all of you. Just mute yourself, because I can't see who's doing, because my screen here, my Zoom is minimized. They've got what we call a toe of a camel. And that if a woman has got a camel toe, we do labia minoroplasty, because this is camel toe came from the fact that this is like a toe of a camel if she put tight gametes. And we can also repair it by doing labia minoroplasty. And after that, she can put tight things. She doesn't have to hide things when she's about among other people. There are type of garments that also are designed with a sponge inside that hide that camel toe inside here, which are in the market, because the market have realized that women need this. All these topics, and it stems from the Bible. During the Bible, they say Adam and Eve, they realized that they were naked. And where did they cover? They took leaves, and with the leaves, they covered the genitals and the breast. Why didn't they cover the face? Because the genital is the most important part of the body. So whenever you don't look after your genital, then it must know the quality of your life is gone. I hear women come by, but it's your life. So in conclusion, although the pelvic floor dysfunction should be simple, it's a complex process which might develop due to multiple factors. With improved medical care and increased life expectancy, women live longer these days. The incidence of pelvic floor relaxation and pelvic organ prolapse will be more. Of course, it comes with financial burden to the healthcare providers. Most especially that majority of these procedures, medical aids don't cover them. They say they are cosmetic, but I don't think they are cosmetic, because they are caused by vaginal birth, which is unavoidable expectation from a woman. So vaginal tightening and vaginal cosmetic surgery is gaining popularity in women who wants to regain their bedroom confidence and remain in monogamous marriage. So nowadays, women, if you can see, I always move around with my gynecological knowledge. If I am at a wedding and see women dancing, I know that these women, they don't have pelvic organ prolapse, they don't have genital relaxation, they don't have urinary incontinence. If any woman can do like that. The aim of this webinar was to remove the stigma and the stereotype and secrecy of genital ailments in women. Thank you very much. I've lost my grid here. Let me go and look for it. Okay. This is the time that we must ask questions. We must ask questions. And I can see majority of them has got pictures here. This is the time for questions or comments. You don't have, I might not have all the answers. This is like a social topic, you know. You might be knowing more than me about these things.
No, indeed. I'll go unmute.
Okay, I'll allow you to unmute. I haven't yet allowed you to unmute. I'm still talking, Menier. Let me go somewhere and allow you to unmute. And if I allow you to unmute, let me see. Where do we go? Audio. There's somewhere we must allow you, as participants. Very easy. Choose share slide. Anybody who knows how to make you allow you to unmute?
Can you hear?
Raise your hand. If you raise your hand and I can say unmute, you'll unmute.
Raise my hand. Raise my hand.
Hold the phone tight
Raise your
in your
hand.
hand.
Let me see.
We can unmute ourselves.
Huh?
We can just unmute ourselves.
Okay,
Yeah.
I made you unmute. Okay, so Rebecca di Gamela, le kae ngwana esho ga mphatlhele monna kgadi ya bakgaga le kae gomme. I see the hand of Rebecca di Gamela is up.
Re bona ka ra lena Dr. Mahapa.
Re gona.
Ya ka question ke re can a woman without intrapartum exposure except trauma or congenital issues suffer from some of these conditions?
Yes, if you look at the etiology, I said congenital diseases. If you've got diseases like Ehlers-Danlos, connective tissue diseases, you've got poor collagen by yourself, you'll suffer the prolapse without any delivery. Being a nun, you can still suffer it, but that's very rare. Yes, you can, depending on the quality of your collagen. Anybody take the hand down, the Gamela? Any comment? Manier, will you go comment? Am I audible? I can't see the hand here.
I think Relevora Ngaka Mahapa.
Tobela, kinga ka motlantle.
Kinna.
Tobe.
Not really what your education. I mean, it's helpful, especially to a woman who you said sometimes hide these things. Then you start getting marital problems. One thing which really just worries me is that why do women have to go through all these things? You know, I mean, a woman gets pregnant and then she carried the baby for 9 months. She gets pains to deliver this baby. And then she gets torn muscles of the pelvis and all these things. Then she has got prolapsed organs. The man leaves for a young woman. Then she has also get beaten, like gender-based violence. So why didn't God come with another mechanism, of equalizing both the man and the woman? Other physiological, anatomical issues. Why must the woman bear the brunt? Just the last thing, Prof. Mohogong used to say, people must never have more than 2 children. He said the first child, The second child is for economical reasons. If you do have the third child, then you must be taken to a mental hospital. Thank you.
Okay, thanks. And maybe the audience can answer it. I'm a Christian. I can just say that when the first sin was committed, the punishment that was given to a man is that you will deliver with pain. But it didn't say after delivery you'll have consequences of delivery. And the punishment that was given to a man is that you will sweat to a lap. I don't know why women are waking from a lap. Well, that's their choice with women equality. The man must provide. Okay, let's not go into that direction. Thanks, Dr. Mutlanti. Anybody who wants to comment or to augment?
Thanks, Dr. Mahapa. Thanks for the presentation, and it was so good.
Get Dr. Magoti.
And informative. I'm talking. Can you hear me?
Dr. Magoti.
Yes.
Oh,
so I even sent this presentation to some of my patients. And thank you very much. It was so informative. Keep it up, Papa.
Thank you, Minier. Vasadi, Ari Vasadi. Arqui. Lirin. Vasadi Wari. When even they've got prolapse, they don't talk.
That's one.
Our Minier Riboni Maria Chusha. So I don't know what to say.
I choose Mama Koti Nonge.
Nobody
the aim of this webinar, I've said when I introduced that, to open the stigma to another stigma. Basadi babulele, ababulele until babathala. Rosa Manuel, ulukara bojang.
I'm just surprised. Yeah, but it's so informative. We enjoyed it, Doctor. We enjoyed the presentation.
No, this is not fun. It's not Kaiser Chiefs versus Orlando Pirates. What do you think about it? Let's hear experience. Teach the young ones.
Hi, Doctor. I really appreciate the presentation, which was very much informative. And for somebody who comes from medical background, I'm a professional nurse.
Yes.
I've come across a lot of these things, more especially, I worked for a long time in maternity, delivery ward especially, where if a woman, sometimes a woman comes to deliver a baby, whereas already they had the perineum that is germeka. So actually, where we would even have to alert the doctors that no, this one needs like to be repaired as in now, because we know the meets.
Yes.
So this is very, very, very important information. But nonetheless, but what I have heard is very, very, very important. I was even able to send it to other women to attend. I just came across it while you were already in the middle of your presentation, and hoping we'll still have more of this nature going forward. I've seen some on your Facebook page, and I really appreciate it.
Thanks. We heard from the midwife, the people who see them every time. Cleopatra Matukuma. You can't just put it. Argon now ring from Joburg. What was the experience in Joburg? He has just passed a comment here, Cleopatra. Nice, quiet. Doesn't know. Maybe shame. Konu Robert.
Hey, doctor.
Hey, you?
Yes, doctor. No, Joburg is good. There's just rain, but yeah, we're enjoying the rain.
We're enjoying the rain.
Yeah.
There's no prolapse. There's no pelvic floor relaxation. Joburg is fine. You know, the midwife who have just talked here, you must ask her about Joburg Prime. Now, what's a Joburg Prime? Well, they used to talk about it in Garango. Ladies and gentlemen, you can spend the whole night here. Thank you very much. I want to show you that really, women, they are very important. Bashweshwe, amukitolelela kakosa ya Bashweshwe. Bashweshwe, the South Sotho, they are not afraid to talk about these things. Even their songs, they sing about them. Thank you, ladies and gentlemen. This is the end of the webinar. In December, there's no webinar. That's why I say Merry Christmas to each of you.
Thank you, Dr. Mahapa.
I also want to enjoy Christmas.
Thank you,
Dr. Mahapa.
Thank you. Bye. We enjoyed the presentation.
There's a very nice attendance.
Bye,
Doctor.
Next year, January.
Enjoy your Christmas. Thank you.
Bye.